Okay, so as you can see, we spoke about how the accumulation of the little RBCs was happening inside of your proximal tubule. And suddenly they have cleared out from the proximal tubule inside of your urine to make some structure looking like this. And when you see this, the moment you are looking at it, it can be red, but it's not always red because, you know, it can be like this pigment can be different from like one cell to another cell. Yes, so this cast will be in the urine. So if you take a look at this cast, does it have any nuclei inside of these cells? Can you see any nuclei? No nuclei, that means it's an RBC, yeah? So, since you have been able to see this, I'm going to show you another type of cast. So, before I tell you, I show you another type of cast, can someone tell me please, regarding this cast, is it made in your tubules or after your tubules? Tubules. Okay, so it's inside of the tubules. So if I say someone has a lower urinary, if someone has a lower urinary tract infection, will he have formation of these casts or not? Not. Exactly. He will not. Only if it was an exact pathology in the like kidney itself and the tubule themselves. Okay, since there is an RBC cast, there must be a white blood cell cast, which is really common in case of inflammation of the kidney. So let's take a look at it. Can you see, let me just copy this, post it here. Okay, can you see here inside of this picture, there is multinucleated cells which resembles neutrophils, yeah? You can see nuclei inside of it. So that makes it a white blood cells. And this is a cast because it was casted inside of the tubules. Okay, one more picture. So in symbol, when you have a cast, your main function is to zoom in into it, okay? And when you zoom in, you will be able to see which form of cells is it made out from. So if it was RBC, it's an RBC cast. If it was white blood cells, it's a white blood cell cast. And soon I'm going to tell you about one more type of cast, a grain cast, but let's wait for it for a second. So granular cast basically. So first of all, what I want you to know that the cast is formed inside of the tubule. So any pathology after the tubule will not lead to formation of a cast. With simple microscopy of the urine, you will be able to see the casts. So cast in the urine. A presence of cast indicate hematuria or biuria. Hematuria means blood in the urine. Biuria means pus in the urine. Is of a glomerular or renal tubular origin. So it cannot be lower urinary tract problem. It must be upper urinary tract problem. So speaking about the cast in the urine, the pathology must be either in the glomerulus itself, leading to a lot of blood going to the Bowman's capsule and the BCT, or the problem need to be in the tubule themselves, but it cannot be after. That's the main idea. So in case of a bladder cancer, is a bladder cancer, think about it, just here. Bladder cancer, is it before the kidney or after the kidney? After. It's true that it will be bleeding. Bladder cancer bleeds, but will it have cast, RBC cast? It will not. Why? Because it's after the kidney, and the casts normally are formed inside of the tubules. The same story with the kidney stones, okay? So there will be hematuria, but no RBCs. Okay. RBC cast, of course. No casts, so yeah, there will be blood, but no casts. Okay, the next one is acute cystitis, in which there is biuria. There is biuria, which is white blood cells in the urine, but no cast. Why? Because it's not Nephritis, it's a lower urinary tract infection, not an upper urinary tract infection. In contrast, if it was upper urinary tract infection with an inflammation of the glomerulus itself, and it could be secondary to pyelonephritis, that will lead to formation of white blood cell cast. Okay, let's speak first of all about the RBC cast. So in first aid, they give really bad picture here, and it's basically supposed to be an RBC without a nuclei, and you are supposed to think that it's an RBC cast. So RBC cast can be in a glomerulonephritis, as we said, also hypertensive emergency. In case of hypertensive emergency, what happens to the hydrostatic pressure inside of the glomerular capillary, guys? The hydrostatic pressure will increase significantly. Okay, so when the hydrostatic pressure increases, initially there will be more filtration, and even some RBCs will be squeezed out. And when these RBCs will be squeezed out, that will lead to passage of some cells will be passed into the urine. Okay, so let's take a look here. Okay, by the way, if I'm passing the RBCs through the filtration membrane, will it go inside of the urine intact or it will be damaged? Of course it will be damaged. So if the RBC's structure is intact, think about a lower urinary bleeding, okay? Lower urinary tract bleeding. But if it is dysmorphic, think that it had to pass through the really thick filtration membrane, which will lead to alteration of its shape, you know? I mean the RBC. So here we have a granular cast. A granular cast, it goes something, white blood cell cast. White blood cell cast, there is a lot of cellular cells inside of the urine. Inside of the cast, basically. This is the cast here. And it can be due to tubular interstitial inflammation, which is one of the first diagnoses I ever made in my life. I felt like Dr. House. So basically, these patients with the tubular interstitial inflammation, it happens because the people do have a serious problem like after consuming a drug. That drug is basically lead to some form of hypersensitivity reaction, and that hypersensitivity reaction we name tubular interstitial inflammation. What did you say about dysmorphic? So if I say that there is a filtration barrier, like in the Bowman's capsule, okay, you have your filtration barrier. So you remember you had in it your endothelium, your basement membrane, and your podocytes. So if there is an RBC here, and you want to pass it to this area from point A to point B, is it going to be intact when it reaches the point B, or it's going to be this one RBC, it's going to be dysmorphic, like change the structure of it? It's going to change the structure a little bit, yeah? It's going to become like looking weird, something like this. We call it dysmorphic. While if the bleeding was from the lower urinary tract, let's say it's because of a stone inside of the ureter, it's not getting squeezed. The red blood cells will be intact. So if you look at the urine picture under microscopy and you see intact RBC with no casts, you are highly suspecting this or this. Are you suspecting an upper or lower bleeding? Tell me, if the RBC is intact, is it an upper or lower bleeding? Yeah, if it's intact with no problem, it's lower. But if you look at the same thing and you see here something like this, there is a cast, there is many RBCs inside of it, and in addition there is like this dysmorphic RBC here, dysmorphic RBC there. What are you thinking about? Is it upper or lower? Bleeding. Upper, obviously, because it must have been passing through the filtration barrier, filtration membrane, for it to change this structure to this way. Yeah. Okay, so tubular interstitial inflammation is due to eosinophils, and these eosinophils accumulate inside of the kidney and then start becoming filtrated, which lead to them to make white blood cell casts. So the next thing is acute pyelonephritis. The acute pyelonephritis goes something like this. If we speak about pyelonephritis, it is an inflammation of the what? Of the kidney. So it's the upper kidney or the lower kidney? It's the upper kidney. Since it's the upper kidney, there will be white blood cell casts formation. The same thing with the transplant rejection is the kidney itself that is dysfunctional. Let me contrast this with a patient who have cystitis, which is a bladder inflammation. In a bladder inflammation, will you have a white blood cell casts in the urine? No, you will not have a white blood cell cast in the urine. That's true. Come on, guys, we are like 12 people in this group. Come on, join. Write answers on Telegram. It makes you get the info much better. So if we speak about the urethritis, will you have white blood cells in the urine? I'm not saying cast, just normal white blood cells. Normal white blood cells you will have, but you will not have casts. That's the thing. You will not have cast. Yeah, as we said, cast only if you have a glomerular or renal tubular origin. Because I showed you that this casting process is happening inside of the tubule. So it cannot be a patient suffering from urethritis, which is after the kidney, having a cast. It's not possible simply. Okay, granular cast now. Granular cast happens after acute tubular necrosis. If we imagine that this is your bulbous capsule and it's going to the BCT, inside of your BCT, something will happen that it has cells on the walls, yeah? During acute tubular necrosis, these cells on the walls will start breaking and falling down, yeah? And they will fall down and will lead to a mesh. Since it's necrosis, in case of necrosis, we have a loss of the nucleus, okay? We have loss of the nucleus. And when we lose the nucleus, the process of necrosis is continuing, which will fill up all of the BCT. And when the BCT is filling, we have formation of what? A granular cast, which does not have any nuclei inside of it, okay? So it can be muddy brown in appearance, as you can see here. Let me show you some muddy brown cast, actually, because this is quite important. Muddy brown cast. So the moment you see a muddy brown cast, you think about acute tubular necrosis. So this is a muddy brown cast, this is a muddy brown cast, this is a muddy brown cast. Yes, we will be speaking about each of these conditions deeply. This is just a general overview, and like I will be coming back. For now, the only thing required from you is to know where is the cast made and how it made. That's it. You don't need to know pyelonephritis, interstitial nephritis. No. This is for later. So yeah, for now, this is a muddy brown cast, and yeah, I hope you get it. It's look like poop. Yep, exactly. It just what? It just some of the cells inside the epithelial cells of the BCT have sloughed off inside of the tubule. Okay, the next one. The next one is fatty casts, oval fat bodies, which are seen in Nephrotic Syndrome. Later I will tell you why do we have fat inside of the urine in case of Nephrotic Syndrome. But this fatty cast are actually looking quite cool. The first time I saw it, I thought it was fake, but apparently it's right. So Maltese Malta. Maltese. What is the... Oh, you cannot hear me, guys? Let me check. Okay, can you hear me, guys, normally? Okay, so there is something called the Maltese Cross. Let me show it to you. This is the Maltese Cross, which is the symbol of the country Malta. And there was a Maltese, different type of Maltese. There is the Maltese Cross, which is seen in babesiosis. Okay, now we are going to speak about the Maltese Cross, which is seen in case of Nephrotic Syndrome. And it's seen because of fat inside of the urine. So take a look here, guys. This fat, it makes this structure on basically microscopy, dark field microscopy we call it. And you can see it, and the moment you see it, you have diagnosed it. Why? Because it looks like a freaking Maltese Cross. And this is highly specific for nephrotic syndrome. Okay? Later I will explain exactly why nephrotic syndrome have fat inside of the urine. Okay, so let's go to the next one. The next one, it's about Waxy Cast. Waxy Cast, I told myself always, you will have Waxy Cast when your kidney is whacked. Okay? Waxy when it is whacked. So Waxy Cast happens in case of end-stage renal failure. And okay, so in end-stage renal failure. And also in chronic kidney disease. As you can see, both of these stages tell us that our kidney is whacked. Okay, so Waxy Casts we spoke about. Now the last one, Hyaline Cast. It's a non-specific, actually not relevant even clinically, but why are we studying it? We are studying it so when you see it, you will not be thinking about a really bad pathology related to the kidney while it's something else. So the Hyaline Cast looks something like this. Can you see what is inside of it? Exactly, nothing. So it's a non-specific, can be normal finding, formed via solidification of something called the Tam-Horsfeld mucoproteins, which we'll speak about a little bit later. They are secreted from the renal tubular cells of the BCT. And in case of dehydration, for example, what happens to your specific gravity of the urine? What happens to specific gravity of the urine during dehydration? Specific gravity of the urine during dehydration becomes more, because the urine is becoming more concentrated. The same thing with a pre-renal acute kidney injury, which means that, you know, in case of a pre-renal, it could be like for heart failure, due to heart failure, for example, in which will lead to less perfusion to the kidney. Less perfusion to the kidney can lead to what? This Tam-Horsfeld mucoprotein starts going from your BCT to your urine and forming you this Hyaline Cast. Okay? So let's take a look at a few words that you must differentiate from. So here is the cast, you know where they come from the glomerulus or the tubules. This is what is important for you to know right now. Later we will speak about each one and each of these pathology in depth. The next thing I want you to know is about now we are going to speak about naming stuff. So when we say acute kidney injury, AKI mean acute kidney injury. So focal, when we say kidney pathology is focal, what does it mean? So here, for example, you can see focal segmental glomerulosclerosis. You are like, okay, glomerulo means glomerulus. Sclerosis means hardening of and making of fibrotic tissue in it. That makes sense. But what is this focal segmental? Well, focal mean it affects less than 50% of the glomeruli. Okay? Focal means it affects less than 50% of the glomeruli. While if you use the word diffuse means that it affects more than 50% of the glomeruli. And the word proliferative, such as in case of membranoproliferative glomerulonephritis, it's a proliferative. So there will be hyperproliferation of what? of the glomerular cells. So hypercellular glomeruli. And the next one is membranous. Why we are studying this is just for histology. When we will look at it for each pathology, we'll know, okay, focal means like less than 50%, diffuse more than 50% are affected. So it's just general material for now. So there was thickening of the glomerular basement membrane, and that can be such in case of membranous nephropathy, which basically indicate thickening of the basement membrane. The next one is a primary glomerular disease and secondary glomerular disease. Primary glomerular disease means that the primary disease mainly affects the kidney. It's the main impaction and dysfunction is in the kidney. For example, minimal change disease. Secondary glomerular disease, it means some extrinsic form of pathology is causing dysfunction of the kidney, but the primary pathology is not in the kidney. For example, systemic disease or disease of other organ system that are impacting the glomeruli. For example, lupus. Lupus is an autoimmune disease, but it can affect other systems such as like the kidney. Remember, lupus hate two organs, the heart and the kidney. Can someone remind me what lupus led inside of our heart? It led to one pathology in the heart. Sterile endocarditis, that is correct. Yep. So the next thing you must know is going regarding the, where it is, yes, okay. So done with this page. Now it starts becoming interesting because this thing is just like general material. Now it becomes more specific. Okay, so speaking about the glomerulus diseases, as you can see, your glomerulus, basically your filtration barrier has 3 layers. The innermost layer is your glomerular capillaries, which contain endothelial cells inside of them. After that comes what? The basement membrane. After the basement membrane, what do you have? Your podocyte. Another name of podocyte I told you about is the epithelial cells of the basement membrane. So epithelial cells and podocyte, these two words can be used interchangeably, okay? So the next thing you must know about is where it is. Yes, here it is. So we have nephritic syndrome, nephrotic syndrome, and nephritic syndrome. What does that mean? Well, in a second I will tell you what is each, but for now I want you to know that if you have nephritic syndrome, it can become nephrotic, okay? If you have nephritic, it can become nephrotic. So let's take a look. Well, here it goes. Look what they write here. Mechanism of formation of nephrotic syndrome. How nephrotic syndrome occurred. So there is an underfill mechanism and an overfill mechanism. What does that mean? It means that it could be because of the glomerulus of your kidney has become more permeable. The Kf of your kidney is becoming higher. So there will be more glomerular permeability, which increases uroproteinuria, which lead to hypoproteinemia, which decrease oncotic pressure leading to edema. Yes? Also, decrease in the oncotic pressure lead to hypovolemia, activation of the RAS, lead to more sodium and water retention. Yep. The primary renal sodium retention can lead to hypervolemia as well, increasing the hydrostatic pressure, which lead to edema as well. Anyway, this stuff we'll speak about later. For now, you just need to know the general pathology and what it means. So in case of nephrotic syndrome, the problem is in the glomerular basement membrane. That's it, okay? It's not in anything else, and that's the thing you must master. Nephritic, it's in the glomerular basement membrane, which is located between 2 layers, the epithelial cells and the endothelial cells. Which type of collagen is inside of a glomerular basement membrane? It's type 4, yes. So it's, they write, glomerular inflammation will lead to glomerular basement membrane damage, loss of RBCs into the urine, leading to hematuria. Okay, hematuria, Rbc cast in the urine, decreased GFR, and oliguria. So oliguria will be as well. Also azotemia. So again, hematuria, Rbc cast in the urine, and decreased GFR. So there will be blood in the urine. Before I continue, this problem is happening at the glomerulus. So will there be casts or not? Yes, there will be casts because it is, I told you, any pathology that is happening at the level of the glomerulus or at the level of the tubules will have actually what? It will have this casts. Okay, so hematuria, Rbc cast in the urine, and there will be low GFR. You're like, wow, how is GFR even related to this? Well, because of many reasons. One of them that you have destroyed basically your filtration barrier. Your GFR is not maintained anymore. So also that can lead to oliguria when you destroy your filtration barrier. Okay, also azotemia. Can anybody know, does anybody know what azotemia mean? Yes, increase in the BUN, which is basically how much nitrogenous particle do you have inside of your blood. For example, urea is a nitrogenous particle. Ammonia is a nitrogenous molecule. So BUN is the blood urea nitrogen, which represent how much urea basically and other nitrogenous particle you have accumulating inside of your basically plasma. Okay, so there will be also more renin release. I will try to change my position, maybe it will work. Just a second. Can you hear me better, guys? Is it better now? It's not better, no? Oh, you cannot hear anything now. Oh, damn it. What is happening? Okay, what about now? Okay, let me try to go out and back in. Hello everybody, can you hello everyone, can you hear me now? Okay, good. So let's take a look. Speaking about azotemia, is it due to, yes, of course I can repeat about BUN. So BUN, the blood urea nitrogen, the idea that any particle that has any nitrogenous material inside of its chemical structure will increase your BUN level, okay? So BUN level represents the what? The amount of nitrogenous material inside of your blood. There is many nitrogenous material that can be inside of your system. For example, take it. First of all, ammonia, urea. Also, like a patient who had, for example, some type of bleeding in his body, then you will have to, like inner bleeding, I mean, then he will have to metabolize that bleeded blood. Yeah, for example, he had a GI bleed. Your intestine will not let that products, nitrogenous product from the blood go to waste. It will reabsorb it, which will lead to increased plasma amount of nitrogen. Yes, so your BUN goes up. Yeah, and other than that, there is many causes of increased BUN, which is anything that has basically nitrogen inside of it. And if to be fair, also if you eat a lot of proteins, like and you need to be careful about this one. For example, bodybuilders, since they do a lot of weights and stuff like that, they can have actually increased BUN without having actual pathology. Okay, so because the proteins contain amino acids, and amino acids have a nitrogenous group, and that nitrogenous group can lead to increased BUN. Yeah. Also, athletes have an increased CK, which is creatine kinase, and it happens due to the destruction of their muscles. You are like, no, they are building muscles. To build muscle, you need to break it a little bit. So basically the muscle breaks a little bit, and after that you have building of new muscles around it, and that's why you have hypertrophy of the muscle. Never hyperplasia, because it's in G0. So the next thing you must know is Nephritic Syndrome. They write hematuria, RBC in the urine, decreased GFR, and oliguria and azotemia. Increased renin release as well. So there will be more renin release from the kidney. Also, oliguria is decreased amount of urine in the blood. So oliguria, decreased amount of urine. Anuria is absence of urine. Buliria is urinating so often. Okay, so increased renin release will happen due to the kidney dysfunction. Basically, you remember the guy who the organ that was responsible of controlling the RAS system was the kidney. Also, hypertension can occur in case of nephritic syndrome, which we'll speak about in a second. Why? Because of the increased renin activity, basically. So, okay, so renin activity is increased. How that lead to hypertension? Well, the RAS system, more angiotensin 2, more aldosterone, that will lead to hypertension. Proteinuria is often at a subnephrotic range, which means that it's not high enough to reach nephrotic range. And the nephrotic range is anything over 3.5 grams per day. You are like, wait, so are you saying that we need to check the amount of the whole amount of protein for the urine for the whole day? So we will collect all the urine of the patient for the whole day? Well, the gold standard is that actually, but we don't do the gold standard. I will tell you later what we do, but we do not do the gold standard. Yes, it's possible to do the morning samples, or you even can diagnose it with just a simple urine dipstick, and it will show you like a high amount of protein, making you more suspected nephrotic syndrome. And the plus, if the amount, if there is no blood in the urine and there is a protein, it's nephrotic. But if it's both blood and the protein, it's nephritic. But the number matters for the step 1. So, but in severe cases, it may be nephrotic range. So, what are they saying this? They basically are telling you that nephritic syndrome can become nephrotic syndrome. It can change. So, what are examples of nephritic syndrome? In nephritic syndrome, remember, the main thing was blood in the urine. So, for example, acute post-streptococcal glomerulonephritis, which is a condition I will tell you about soon, in which the patient, come on, can you hear me, guys? Okay, if it happens again, please let me know. Okay, so acute post-streptococcal glomerulonephritis, it will lead to nephritic syndrome because after getting affected by the Streptococcus pyogenes, this Streptococcus pyogenes will stimulate the immune system to create some antibodies. It's a whole process that we'll speak about like in a few minutes, actually. Next page. And yeah, the patient will have attack of his glomerular basement membrane, which lead to destruction of it, which lead it to pass a lot of RBCs into the urine. Okay, so the next pathology is rapidly progressive glomerulonephritis. The next one is an IgA nephropathy. Guys, do you remember where we saw IgA nephropathy before? We saw it. Vascular, but what exactly in vascular? What type? What was it about? It was a form of a... Remember IgA nephropathy, Inhension Burbura. Yep. It's a form of vasculitis, and they had really characteristic skin finding. Which skin finding they had? The third one on the page. Oh yeah, so they have like a rash on their buttocks mainly, and that rash on their buttocks mainly it's palpable but non-blanchable, which means if you press on it, it will not go away. Okay, the next disease is Albert syndrome, in which the patient is having defect of type 4 collagen, which is located in the glomerular basement membrane. The next one is membranoproliferative glomerulonephritis. I will be telling you about each of them. So now it's just an overview of nephritic syndrome, and you must know that it's due to a glomerular basement membrane pathology leading to hematuria with Rbc Cast. That's what you need to know until now. Goodbaster syndrome is different from Albert, because Goodbaster syndrome, I always imagine a pasture having two guns. So these two guns are like firing antibodies, okay? So in case of Goodbaster, it's an antibody mediated attacking the basement membrane of the kidney and attacking the basement membrane of the lung, okay? So it's a totally different pathology. So if we speak about the Goodbaster, it is antibody mediated. If we speak about the Albert, it's just a destruction of the collagen. That's it. And the destruction of the collagen in case of Albert, because you are not making it. While in case of the Goodbaster, because you are making antibody attacking that collagen and destroying it. So remember, Goodbaster has two guns, which he's shooting with at the lung and at the kidney. Okay, so the nephrotic syndrome, it's a podocyte dysfunction. So the first one was what? It was a glomerular basement membrane. This one is podocyte dysfunction. What does podo mean? Yep, it's foot. So podocyte damage will lead to an impaired charge barrier. Can someone tell me what mediates the charge inside of your podocyte? There was one particle that keeps it negative. Excellent, it's heparan sulfate. Not heparin, heparan. I said that in the first class, if you remember. So there will be an impaired charge of the barrier. Remember, this heparan sulfate was negative charge. And your albumin is also negative charge. So negative and negative verbal from each other. So if you try to push negative against negative, they will not, they don't like each other. Each one will go on its way. Okay? So they will barbell from each other. That's why you don't get albumin into your urine. Okay? But in case of nephrotic syndrome, this charge is lost. Why? Because it was initially in the podocytes, and now the podocytes are damaged. So you will have a massive proteinuria, which is more than 3.5 grams per day, with hypoalbuminemia, and that will lead to edema. Guys, what will be affected in this pathology? Your oncotic or hydrostatic pressure? The oncotic pressure, excellent. So your oncotic pressure will go down big time, because we said that the oncotic pressure is mediated by the albumin. So frothy urine with fatty casts I'm sorry, but I have to show you a frothy urine. So a frothy urine is like when you when they go to the bathroom and they urinate, it makes a lot of foam. Okay, so when they look, yeah, something like this, it makes a lot of foam. Or when they give you the specimen, it looks like a beer. Exactly. Yep, a lot of foam. I know, right? That's why you learn medicine for. So, next one. So the next one is, yeah, frothy urine with fatty casts. And it's associated with hypercoagulable state. Oh, let's speak about the fatty cast first of all. So in case of nephrotic syndrome, what you are losing in your urine? Proteins, correct? So since you are losing proteins, do you remember something called apolipoprotein? So this apolipoprotein is normally located in which organ? Apolipoprotein function normally is, it has multiple function. It's in the liver and it has multiple function, which is basically keeping the fat, taking the fat back to your liver to be dealt with inside of the liver with the beta oxidation process. But since this is not happening because you don't have apolipoprotein. Why you don't have apolipoprotein? Because you don't have a protein. Why you don't have a protein? Because the kidney is excreting all of the protein. So that will lead to hypercholesterolemia inside of your body because the fat will not be able to go back to the liver to be metabolized. So it will be accumulating inside of your circulation, which lead you to have hypercholesterolemia. Yes. Also, you can form fatty cast in your urine as well. And also this nephrotic syndrome will lose one. So the first protein we lost was albumin. That led to what? Edema. The second protein we have decreased is apolipoprotein. That led to hypercholesterolemia and fatty liver. The third protein we lost is the antithrombin 3. So what is this antithrombin 3? I will speak about a lot about it in hematology, but for now what I want you to know that there is a good guy called antithrombin, okay? And that guy is a hypocoagulable particle, which should prevent your body from doing coagulation, yeah? So this is basically, this antithrombin is killing the thrombin, okay? And does anybody remember which drug attached to the antithrombin 3? Which drug attached to the antithrombin 3? There is a drug. Heparin. Heparin attached to the antithrombin 3. And in case of nephrotic syndrome, you are losing antithrombin 3, which lead to a hypercoagulable state. And also there is increased risk of infection. Why? Because you are losing a lot of IgGs, immunoglobulin Gs, which are proteins. And thus, you can lose them in your urine. Actually, they are glycoproteins, but it's fair enough. Fair game. Okay, and soft tissue compromised by edema. So basically, there will be a lot of IgGs inside of your urine. And since it's inside of the urine, what happens to your immune system? That it goes down. There is many causes. So they write maybe primary due to direct podocyte damage or secondary podocyte damage from systemic process. We'll speak about all of these. So, for example, there is this focal segmental glomerulosclerosis. When we say focal, is it more than 50% or less than 50% of the glomeruli affected? Less. Okay, good. The next one, minimal change disease. And the next one, membranous nephropathy. Remember, this meant that there is a lot of basement membrane has become much thicker. Amyloidosis, here we go. We spoke about it the other day. So can someone tell me regarding amyloidosis, what is it made out from? Amyloidosis. Beta protein, beta-plated protein. Excellent. And I want you to make a note, actually, about amyloidosis. It's not in first aid, but you must know it. Amyloid proteins are mostly accumulating in the extracellular space. Extracellular space. Make a note about this. They do ask about it. Okay. And the diabetic glomerulonephropathy, and we will be speaking about all of these after the break. For now, let's take 10 minutes break, and I will